Veronica and Jen Know Everything. Today we're going to be going over disorders of the esophagus. So to begin with, we have GERD. So this is mucosal damage due to abnormal gastric contacts coming up. As far as clinical manifestation, you're going to find that these patients have heartburn, they're going to have a cough, and one important thing is that symptoms must be present 2 times per week for 4 to 8 weeks. As far as treatment, you can do lifestyle modifications, for example, decrease alcohol use, coffee use, smoking, meds as well, so antacids, H2s, PPIs, and we also did a video on this, so if you have any questions, I refer to that. Now moving over to esophagitis, so there are 3 different types. We have Barrett's, we have EOE, and then we have Candida. So to begin with, we'll do Barrett. So this is going to be somebody who comes and tells you they have a long history of chronic GERD, which then would be the result of Barrett's. So what you'll find is that you're going to do a biopsy, and they're either going to have metaplasia, dysplasia, or adenocarcinoma. As far as diagnosis, the gold standard is going to be that endoscopy, and then the biopsy to determine what stage they're at. With treatment, it's going to be indefinite PPIs. And then if they do have dysphagia, you're going to be doing the max dose, which is 2 times daily. Now moving over to EOEs. So this is eosinophils in the esophagus, which they should not be there. You're going to find this person has a history of a food or environmental allergy. They're going to show central chest pain, heartburn, and the diagnosis is going to be the EGD. It is going to be diagnosed if they have greater than 15 eosinophils on biopsy. You may also see rings on your endoscopy. The treatment is going to be food elimination, such as those that cause allergies, dairy, nuts, and then PPIs, and then one big thing is going to be swallowed fluconazole, which is a steroid. Now we're going to move over to Candida. So most likely these patients are going to be immunocompromised, so it's good to get that history. You're going to confirm with an endoscopy. Treatment is going to be an antifungal, oral, and then risk would be if they're on a steroid currently. As far as symptoms, so they're going to have difficulty swallowing, they're going to have pain with swallowing, and they're going to have chest pain, heartburn, and then they might say something about like a globus sensation, stating that they have like this feeling of something in their throat. So now we'll go ahead and move over to Shannon.
So Veronica went over GERD and 3 subtypes of esophagitis. I will be going over 2 motility disorders, Mallory-Weiss tear, esophageal cancer, varices, and stricture. So to start off with motility disorders, both types of motility disorders have very key things that you have to memorize. So to start off with, esophageal spasms. This is when you just have spasms throughout your esophagus, and when you do a barium swallow, it's going to look like a corkscrew from just all the spasming. Kind of changes the anatomical structure of your esophagus a little bit. So there's going to be chest pain and a feeling of food being stuck. You can see that feeling of food being stuck in other disorders, so really focus on the chest pain comes with the spasming, because you can picture if those muscles are spasming up, you're going to feel them. It's going to be a little bit of referred pain to your chest. And then hot and cold liquids can exacerbate this. So the way I remember esophageal spasm, memorize spasm and screw, so it has this corkscrew appearance, and then hot and cold liquids make it worse. So I remember you had a cold screwdriver, and it made your esophagus spasm. So just make sure you have that memorized down. The spasm, corkscrew, hot and cold liquids. The next one is achalasia. Achalasia is going to be contraction of, at the end of the esophagus, the lower esophageal sphincter. So it's different than esophageal spasm in that the esophageal spasms don't affect the sphincter. So achalasia is the sphincter, and you can picture it's contracted right here. So it's going to back up, and your whole esophagus is going to be super dilated. And then you're going to get this bird's beak, which essentially means like you have dilated all the way down your esophagus, and then right before your stomach it kind of comes together, so it looks like a little bird's beak. But just remember, like, the dilation is very pathognomonic for achalasia. So lower esophageal sphincter is contracted. Some things you'll hear: I have to drink a lot of water to push things down because the food's just me sitting right there at the top of the lower esophageal sphincter. And then I ate chicken and it came back up like chicken. That's the classic. I think that's so weird, and I guarantee no one has ever said that. But diagnosis, barium swallow. We do this anytime there's an anatomical problem, so remember, it's not a scope like everything else. It's a barium swallow first. And then treatments, there's a couple options: surgery, Botox, cardiac meds. Cardiac meds like calcium channel blockers, nitro. I'm not sure why those help with achalasia. I think just more vascular flow maybe? I really don't fucking know at all. So moving on to Mallory-Weiss tear. So this is going to be a tear at the gastroesophageal junction, so kind of similar to where we have that achalasia problem. It's from severe vomiting, generally from alcohol intoxication. So I remember Mallory-Weiss, Mallory Weaver, my sister, got too drunk and puked. So you'll see the hematemesis and melena because it's a tear, so think of all that bleeding. If it's really bad, obviously, if there's melena, that's indicative that it's really bad. If there's hematemesis, that's probably more mild, I would assume. So you can do labs, endoscope, EGD. Treatment, they generally resolve if they're superficial tears. Give them nausea meds, avoid NSAIDs, of course, because that's going to cause more ulceration in the stomach. And then if it's a really severe bleed, you're going to have to go in and do surgery. So that's a Mallory-Wise tear. Esophageal cancer, there's the main sign and symptom is dysphagia. So we haven't had anything else that's the #1 sign and symptom. So if the question has difficulty swallowing as the main symptom and then maybe some constitutional symptoms, think esophageal cancer. And then as we know, the esophagus, the upper 2/3 is made of squamous cells and the lower third is cuboidal, I think, or something. So we have squamous cell cancer carcinoma, which is the upper 2/3 of the esophagus, and then adenocarcinoma, which you know comes from our glandular tissue. So that's esophageal cancer. We're moving on to esophageal varices. So those are going to be like the little blood vessels swollen. It's going to be from patients with cirrhosis because we know gut gets packed up if you have like too much pressure in your portal hypertension system. And this is another good thing to memorize. Prevention for this is beta blockers. So if you have a cirrhotic patient, they're going to have hypertension, a lot of like pressure in their vasculature. So the way we're going to reduce that, beta blockers bring the heart rate down, and then we won't have as much of that backup in the esophageal varices. And the esophageal stricture, I'm not sure if this is part or like the whole esophagus is narrowed, but it can be from chronic acid reflux, a complication. So if the vignette says the patient's acid reflux, blah, blah, forever, then you're going to start to think this. So the diagnosis as well as treatment is a scope, and then the treatment is dilation with this scope. And then you'll see Schatzki's rings. When you do the scope, it's kind of just like a weird tissue ring. So I remember Schatzki's, esophageal stricture. So to conclude, that is some of the disorders of esophagus. Really, really memorize the spasm, corkscrew, hot and cold liquids, and then make sure you memorize varices. You need the beta blockers, and that is pretty much it. The rest is pretty intuitive. So thank you for tuning in.